Good morning, everyone. So today I am here to discuss about gynecology, some important topics for USMLE STEP to CK. So these are the topics that we're gonna touch. We're gonna touch some basics about the embryology and the development. We'll study about the pelvic organ prolapse and incontinence, urinary incontinence, various types of. We'll study about the vaginal anatomy and pathologies related. We're gonna study about the uterus and its anomalies and fibroadenoma and adenomyosis and different disease and pathologies of uterus. We'll study about the ovaries and related pathology like many of the ovarian disorders, ovarian cancers, and then we're gonna discuss about the overall the cancer of the genital tract, vulva, vagina, ovaries, uterus, and endometrial carcinoma. Then we're gonna study about abnormal uterine bleeding and why there is primary and secondary amenorrhea and how to diagnose it, what to do the next investigation and how to treat it. And at last we're gonna end it with some brief encounter with breast anatomy pathology and what all we need in gynecology for this. So we'll start. It will not be like very detailed or like I'm taking hours to do it. I'm just taking out important points for with the point of view of exam, like what did examiner find important to ask questions about in these. So let's start with the gynecology basics, and it mainly has female reproductive anatomy. We know we have uterus, and uterus is how the uterus is formed. It's from the fusion of two Mullerian ducts, right? So the first question that normally asked is Mullerian agenesis. So will uterus be present? No. So that's like every question how it is originated from the pathology or the anatomy or the pharmacology. Okay, so we're gonna discuss as I remember some of the questions that come commonly. And what are the structures? We know the uterus has cornu, corpus, isthmus, and cervix. Okay, and there is parenchyma, there is ovary. Okay, so both sides. So that's how normal uterus roughly we know the parts. And how does this uterus is placed in the position it is, like how is it standing in the position without being falling or not in the path, coming in the path. It has been many ligaments that are attached to the uterus that are maintaining its position. There can be broad ligament, uterosacral ligament, and cardinal ligaments, round ligaments, and these ligaments hold it in the position. And what is the normal position of the uterus? So uterus normally is anteverted, okay, and it can be retroverted in some cases. So these are different types. Just a second, I'll take a sip of my tea. Sorry. You can just take a second to revise whatever I told just now. Thank you. So what we studied, the uterus is formed from Mullerian ducts. It has some structures. It has a body that is corpus, a cornu. Cornu is mainly where it attached to the fallopian tubes, and there is isthmus and cervix, and we have some ligaments maintaining its position: round ligament, broad ligament, cardinal, and uterosacral, An anatomical position of uterus can be anteverted, retroverted, and slightly it is anterior in the pelvis, the uterus. Now we study about the oviducts. Okay, so they extend from uterus to the ovaries. And segment of oviduct is fallopian tube only. Don't get confused with the name. And fallopian tube. So there are different part, interstitium, then there is isthmus, then comes the ampulla, which is the widest part, and then there is isthmus and ampullary junction, where the fertilization occurs most commonly, and then there is infundibulum at last. And these fallopian tubes, what is their role? They facilitate the ovum from the ovary to come in fallopian tube, and sperm to the fallopian tube, because they have cilia, and that ciliary movement guides both of them. So at ampullary isthmus junction, most commonly the zygote is formed after fertilization. Okay, and how they are attached? So they are attached to the uterus body, and laterally they are attached, these fallopian tubes are attached to the pelvic side walls, and it has blood supply. The interesting thing of fallopian tube, it is a dual blood supply. It has uterine artery as well as the ovarian artery supplying it. So it has a dual blood supply. So we are done with the fallopian tubes. Now we see ovaries. Okay, we have seen microscopic picture, different stages of ovum, and as it becomes the oocyte and gets out and get ruptured, goes to fallopian tube. So it has ovarian follicles, we know, and they are attached to the ovarian ligament, to the uterine fundus, by suspensory ligaments to the side pelvic walls. So side pelvic wall, so we know what does it attach. The suspensory ligaments attach it to the ovaries to the pelvic side wall, and ovarian ligament to the uterine fundus. So they are stable in their position. And with broad ligament, it's in the mesovarium. So broad ligament, the peritoneal folding, it has 3 parts that we'll see further as we go. And lymphatic drainage is mainly through the para-aortic lymph nodes. That is to be remembered. Pelvic also, but para-aortic lymph nodes also. So this is, we get the rough idea of what ovary is. Now the vagina, we know it's a tubular structure. It is 8 to 9 centimeter in length, and it extends from the opening to the cervix opening, the outside opening, vaginal opening. So this is the introitus, and this is where the opening is there of the cervix. So this is your vagina. And what is its main function? It is used for copulation, and it helps in menstrual blood to flow out of the body, and it also acts as the birth canal for the baby. Now we'll go to 2 types of ultrasound that we use in gynae: transvaginal and transabdominal ultrasound. So transvaginal ultrasound, why we use transvaginally, in which cases like lower pelvic mass and high resolution images, because some images we don't want to get influenced by the thickness of the maternal abdominal wall. So with that, and transabdominal ultrasound, we can see images from all over the pelvis and all the abdominal organs. So that's why we can see for any pathologies near the uterus. And so this is the 2 basic modalities that are used. And then we have a very common investigation that we talk about, pap smear. So the cervical pap smear, normally it is done in the OPD. It is screening for any pre-malignant changes that occur in the cervix, and so that we can intervene early and prevent any kind of cancer, cervical cancer. And the main diagnostic test for any dysplasia of cervix is histological assessment, of course, from the tissue biopsy. But this can be detected early on a pap smear and then can be confirmed by the biopsy. Now there is ectocervix and there is endocervix. So ectocervix, which is opens outside, and endo, that is inside. Both of the characteristic is they both have different type of epithelium, different type of epithelium, and there is a transition also from one epithelium to other. Okay, so there is like a squamocolumnar junction, that is the transition area. The ectocervix is lined with squamous cells. Okay, the squamous cells, and the endocervix is lined with the columnar cells. So the transition area is where we want to see the maximum changes for cervical dysplasia. So from there we take a swab for the pap smear. That we'll see how it is done. There is a traditional swab pap smear that we take. There is a liquid based pap smear that we take. So this was about the ectocervix, endocervix, the squamocolumnar junction. And now we can go to different methods to do pap smear. It can be traditional, it can be liquid based. So with traditional, what we do, the samples are obtained using a wooden spatula on the ectocervix, and we have a cyto brush. We have a spatula, we have a cyto brush. So for ectocervix we use spatula, and cyto brushes for endocervical canal, and we rotate it in 360 degree, and the cells are smeared evenly on the glass slide, and these cells are smeared on the glass slide, and then they are fixed with formalin, and then we stain it and visualize it under the microscopy. So in microscopy we can see the cells, if any dysplasia is there. What is the adverse, or what are the drawbacks of this procedure, I would say, is if you are not properly rotating the brush 360 degree, and you are not taking enough sample to visualize, or you are using too much of the formalin, or you are air drying. Artifacts also occur if you fix it after a very long period, and that leads to the clumping of the cells, and so cytology in this case gets difficult. So that is the drawback of the traditional way we do the pap smear. And now we come to the liquid based pap smear, and it is done using cervical broom. So in this there are long bristles that are placed into the endocervix, and outer bristles are placed into the ectocervix. So then the broom is rotated 5 times in the same direction, and we collect and sample all the endocervical cells in the transformation zone. So this broom is then placed in a preservative solution and rotated 10 times very vigorously, so that all the material that is in this broom is collected into the solution. So now what are the advantages of using this method, the liquid based method? See, first of all, there are no air drying, so no air drying artifacts, and there is no if the cells are not enough on the glass slide, or the technique was not right, so this is better. So classical, we use cyto brush and spatula. Liquid base, we use cervical broom with large and small bristles, and both collecting the endocervical and ectocervix, and the endocervical cells from the transformation zone are taken in, and they are placed in a preservative solution and then collected and then watched under the microscope. Now the next important investigation that we do is a colposcopy. Colposcopy we do in OPD only, it's not an inpatient procedure. It is a binocular focal length, short focal length instrument, and there is a light source inside it to look for this at the cervix through a speculum. And why we use it? To see any abnormal cell, okay, any abnormal pap smear cells, or biopsy. We can pass the biopsy instrument and take the tissue in it, so it can help in biopsy for the histological diagnosis. And we can visualize the ectocervix for if there is any abnormal epithelium. So what we do, we put some acetic acid that is diluted onto the cervix to detect the areas of dysplasia. So whichever the areas are abnormal appearing, we biopsy them only. Include punctation, mosaicism, if there is white epithelium or abnormal vessels. So if these, what we'll say about the abnormal area, there is punctation, there is mosaicism, means mixture of two type of cells, there is white epithelium, and there is abnormal vessels. So if these four things you see after applying acetic acid through the colposcopy, so you take biopsy from these areas. So that how colposcopy is very useful in our OPD procedures to look for any cervical dysplasia in the cases that we suspect it can occur. Now other thing very important is endocervical curettage. What we do in the curettage, we take the mucous membrane of the cervical canal and we scrape it whenever we do colposcopy. We use a curette for it. It is like a spoon shaped, and it is usually performed as a follow-up of abnormal pap smear. See, a lady comes, we find some abnormal cells on the pap smear. Suppose we use the liquid pap smear. We found some abnormal cells. So now what we'll do, we'll scrape, we'll do the colposcopy and we'll scrape the abnormal areas that we see. And then we can identify whether it is malignant, dysplastic or not. And it is not done on pregnancy patient because there is risk of heavy bleeding. See, you are using a curette, so you can harm the mucosa around if you don't do it properly. It can lead to bleeding, and that's all about it. I think the endocervical curette. And then again, there are some therapies that we use today to treat the abnormal epithelium according to the grade. Okay, so we know about cold knife cone biopsy. So cold knife biopsy is also outpatient surgical procedure. It is done we can do it under local or general anesthesia. It helps to know about the histology of cervical lesion. So a cone-shaped tissue specimen is obtained with a scalpel by performing a circumferential incision of the cervix. Like this shape, tissue is removed from the cervix. Okay, and so this tissue is sent for the pathology detection, what's the histological diagnosis, and there is wide shallow cone is performed if the pap smear shows any changes, and more severe than the colposcopically directed biopsy. and there is narrow deep cone is performed if the lesion extends from exocervix into the endocervical canal. So they are just saying it is white if the pap smear shows changes more severe than the colposcopy biopsy that we have done, and the cone is narrow and deep if the lesion extends from exocervix into the endocervical canal. The depth is more, so of course endocervix we won't have more endocervix. Now what is the side effect of it? If you take a part of cervix, what will happen? It will lead to cervical insufficiency. So it can lead to? It can lead to preterm birth, it can lead to abortions, and what else can occur? Stenosis. Any instrumentation can lead to secondary adhesions following it if not properly followed up and taken care of. Now next procedure is LEAP that we talk about, that is loop electrosurgical excision procedure, which is a minor outpatient procedure, and we do it under LA, and there is local anesthesia, and it is diagnostic because it establishes the histology of cervical lesion, and it helps to diagnose and treat the cervical dysplasia. How? We pass an electric current through a thin wire loop to remove abnormal cervical tissue, and the loop seals off blood vessels as it cuts so that there is no bleeding, and the tissue that we have taken out is sent for the pathological examination, and we can follow up with pap smear like every 6 months for around 2 years to ensure if there is any dysplasia that will reoccur or return. Now what can be the side effects? Of course the same thing. You are ablating the cervical area. So what will happen? Cervical stenosis and cervical insufficiency. The other thing is cryotherapy, that is very in trend nowadays because of its various advantages also. It is also done under the outpatient procedure, and what we do, we destroy the dysplastic cervical tissue, which we have identified with either the colposcopy mediated cervical biopsy. So how do we do it? In the LEAP, we used to send a wire through which we pass the current to burn out the abnormal cervical tissue. In cryotherapy, we use a probe, and the temperature is lowered around say -50 with liquid nitrogen, and this causes the metal cryoprobe to freeze and destroy the superficial abnormal cervical tissue. So it's all destroyed with the probe, and the freezing lasts for around 3 minutes, and then cervix is allowed to thaw. When you freeze something and then you remove the freezing temperature, so it thaws, it melts down or comes back into the original state, and then again freezing is done for another 3 minutes. So what we are doing, freezing, thaw, freezing, 3 minutes freezing, then thaw, and then again freezing for 3 minutes, -50 with a cryoprobe in the abnormal areas identified by the cervical biopsy through colposcopy. Now the same thing, what will be the long-term risk? It is stenosis mainly, and it can the patient may say that I am having some watery discharge after cryotherapy. So that is normal because the tissue has been destroyed, so it kind of slows off, and we can follow this one also with a pap smear for around every 6 months for around 2 years. Now next is hysterectomy, that is very common in uterine cancer, and to prevent uterine cancer to spread if they are benign. So hysterectomy also, we know there are many types of hysterectomy, that is removal of uterus, and we know it's done under GA, and it can be both diagnostic and therapeutic. So it can be done vaginally, abdominally, laparoscopically, and robot assisted. Okay, and these are the various ways that we get. This is the minimal minimal surgery that we do. It is classically we do abdominal for to see if the surrounding tissue has spread or if there is malignant carcinoma. Then we can do vaginally, that prevents any, we go from the natural orifice, that is the vagina. And then there is robot assisted nowadays. So these are different ways. Now what are different types of hysterectomy that can be done? One is subtotal. In this we just remove the corpus of the uterus, so cervix is intact. Okay, that's why subtotal, not complete. Now total, then there is total. What does total means? Remove the corpus and the cervix both. And it is also called simple hysterectomy also. In simple hysterectomy also we remove the both.